President 2024 and has a previously held key leadership roles including Karnataka State IAP President 2019 and IAP President National Respiratory Chapter 2017 and serve as also Executive Board Member 2013 and Secretary IAP Karnataka State Branch 2012 and Joint Secretary of National Respiratory Chapter and serve was also editor-in-chief in the Journal of Pediatric Pulmonology and Critical Care and is a member of Index Copernicus Scientist Group and has numerous publications in both national and international journals along with textbook contributions and conference presentations. We are truly grateful, sir. Sir, can you please give a opening remarks for this session, sir? Dr. N.K. Kallapanavar, sir.
Thank you very much for this great opportunity. I'm really overwhelmed to see my seniors, colleagues, and all delegates. Indeed, it is a very important, the topic which has been chosen, especially the like minds goes in the same fashion. So especially Dr. Sumita Naik and Dr. Ravishankar, they are heading now in a very, very smooth way. And this type of, the session name has been given. So Samanvay, so taking everybody into the account and making sure that the topic for a pediatrician, which every day, most of the pediatrician, see them, and invariably there will be a lot of difficulty in solving this issue. So in this context, today, whatever topics they have chosen, I think, I hope there are very good cases and they will give us, something like what a day-to-day practice in an office practice one can think of when things doesn't suit well for their thinking. So that is what they are going to present, I believe. So we will see. I wish a great success in this program and thank you very much for this opportunity. Over to you.
Thank you, sir. Thank you. Now I would like to introduce our distinguished speakers. First speaker will be Dr. Priyanka Potti ma'am, Associate Consultant in Pediatric Pulmonology and Interventional Pulmonology and Sleep Medicine at Manipal Hospitals, Bangalore. And she also holds a degree of both MD and DMD in Pediatrics, followed by Advanced Fellowship Training and International Certifications in Pediatric Sleep Medicine. She brings rich clinical experience and multiple research publications, particularly in bronchoscopy and interventional pulmonology. Ma'am, ma'am is here. We are extremely grateful. And next speaker will be Dr. Shruti Kottapalli. Ma'am is a consultant pediatric pulmonologist at Rainbow Children's Hospital, Hyderabad. Ma'am also holds fellowship in pediatric pulmonology and diplomas in pediatric sleep medicine and pediatric respiratory medicine. Her expertise includes asthma, cystic fibrosis, sleep disorders, and pediatric respiratory care. She also has numerous publications like publication on childhood allergic pulmonary aspergillosis and has many contributed chapters in allergic lecture notes. Without further delay, I would like to invite Dr. Priyanka Potti ma'am to take over this session.
Thank you, ma'am, for the kind introduction. Before I start, I want to thank the senior members, our senior doctors, our teachers who are here on the platform today, the Central IAP, Dr. Ravishankara, Dr. Sumita, ma'am, for inviting us. And it's a privilege, I can say, on behalf of me and Dr. Shruti, both to be sharing a platform with our teachers, Dr. Kallapanavar, sir, and Dr. Nagbhushan, sir. Let me start off with my PPT and share. I hope my screen is visible.
Yeah, yes.
Yes.
Right. So the topic, when we say all that wheezes is not asthma, wheezing is a common clinical phenotype or a syndrome. It's a common clinical symptom that we see on an everyday basis as respiratory physicians or as pediatricians. We're always seeing cough and cold, which are recurrent. Now, not all of them are allergic, not all of them move on to asthma, but there's so many other times that we have to look beyond allergy or an asthma phenotype. And that's what we're here to learn today. And I hope to be able able to add constructively to that thought. So I start off with a case. So this is a 2-year-old girl I saw who came with cough for 2 months. She started 2 months back with an episode where she had a cold, cough, a low grade fever. Somebody in the school had a fever and cold. She's picked it up from them. She worsened with cough and breathlessness by day 5 and ended up getting admitted on day 6. On examination, she was noted to have bilateral bronchi. Distress was severe enough that they put her on HFNC right away and she needed HFNC for 2 days. These were the basic blood investigations. The count was slightly elevated, 12,500. The differential was skewed towards the lymphocytic side, 50% lymphocytic dominant, mild elevation of CRP. So, overall, the picture, clinical examination, as well as the investigation sound like a viral infection, possible viral LRTI. She was treated similarly. She was given some azithromycin nebulization. Systemic steroids were also started towards the end of the episode, and she was discharged home with nebulizations. So for next 7 days, she did consistently well. She was progressively improving. By day 8, she started having worsened cough, more fever, and by day 10, she's back at the hospital with distress. This time around, on examination, she not only had roncine on both lung fields, she also had prominent crackles in the right side, only on the right side, mammary, infraaxillary, infrascapular region. These were the bloods. The count is further elevated now to 14,500. The differential is more polymorphic, 60% of neutrophils. CRP is 52. They've also done a biofire, a nasopharyngeal swab panel, which is positive for a metapneumovirus and Haemophilus influenza bacteria. Put together, they thought of a secondary bacterial infection that is following up a possible viral. Started her on treatment with IV augmentin nebulization, supportive care. She did quite well after this, got discharged with 2 weeks of nebulization, Budocort. She promptly improved, but it did not completely go away by the end of 2 weeks. So they got a chest CT as well, which was reported to be normal, and then they moved on and changed the nebulization to inhaler. Gave her a Budocort 200 microgram, one puff twice daily, comes to about moderate dose by that dosing. 2 weeks, she continued to be on inhaler, but the cough persisted. It did not respond completely. Now the cough was more dry. At least 3 nights a week, she was waking up with a disturbing cough. Daytime, she was active, playful, but when she ran around and played, she would cough with a little bit of exertion. Look at the past history. There was one more admission which was similar last winter, a similar viral LRTI. One episode in the monsoon time where she had a viral infection and 10 days she continued to cough post that, treated with nebulization and responded very promptly. There was no personal history of atopy like a eczema or allergic rhinitis, but the father was a diagnosed case of asthma allergic rhinitis and was on treatment. Now, looking at all this, we would think, child fits conventionally into a syndrome of preschool visa. This is the 2024 ERS definition. Child is under 6. There is an objective confirmation of asthma wheezing, at least on, both occasions we had. There's been more than one episode of wheezing. So she is a preschool visa. Now, not every preschool visa is an asthmatic. So this is what is the definition of an asthma in an under 5 child given by GINA 2025. It says that all 3 criteria have to be met, that you should have recurrent acute wheezing episodes, at least 2 in the last 12 months, which we meet. No likely alternative cause for the respiratory symptoms, which I think they have fairly ruled out by doing a CT, which is normal, and a history that is largely okay. A timely clinical response to asthma treatment is expected. Initially, though she did respond, she didn't have a consistent response, and that is a red flag that should tell us that we should not be thinking of asthma in this case and look at further. So this was when the child was referred to me. So when I saw the child was active, well grown, playing around, jumping around my clinic, but when she's jumping around, she's coughing. Her ENT examination was normal. There was no prominent allergic facies, and the clincher in this case was a reduced air entry in the right lung field, which is a very dramatic, not even a mild, subtle finding, but a proper reduced air entry in the entire right thorax. Now, this is where we stand. Before I move on to differentials, can I pass the baton back to our experts for comments, sir?
Yeah. Nagushan, sir?
I think if you look at the case scenario, asthma is a episodic disease. It is a disease that is usually manifesting with generalized symptoms. But this child, the way she presented, had some symptoms particularly localized to one area, which is not at all very common. And that should be a red flag for us to think of alternate diagnosis. Number two, it is said that the response to bronchodilators in a child who has asthma is both predictable as well as satisfactory. You can predict to what extent a child with asthma responds to bronchodilators, particularly when it is inhaled and given in the proper technique. And if you have a child who is not showing that predictable as well as satisfactory response, then I think the red flag sign should be recognized. Number three, maximum duration of a viral VC episode is maximum 3 weeks, usually 10 days to 2 weeks, but it can go on for up to 3 weeks. Thereafter, there is a decreasing trend and children don't usually come back. And if you have a child who is continuing to have symptoms or increasing symptoms or symptoms not showing response as predicted, then the thought process that it could be something other than asthma comes to the mind. Number four, there is something called the genetic endowment, and that is children who are born with small airways may behave a little differently as compared to children who have been born with normal birth weight and normal airways. And this tendency can go on until the age of 3 years, after which this tendency reduces. So the child's birth history, an insult to the child's airways at birth or in the first 3 to 6 months, all these things add. Over to Professor Kalapanam.
Um, Thank you, sir. I think what is important here is if you go through the history, yes, there is definitely a three predominant episodes of wheezing is there. But what is more important, whenever you encounter such cases, first thing is one has to make convinced that the noises of respiratory system. So younger the age, always this mistake tend to happen. So I feel personally, whoever is the consultant or whoever is the postgraduate, he should first register how these sounds looks like. Is that what is heard is a wheeze? Is that what is heard is a strider? Is that what is heard is a grunt? Or any combination of them? So if one can able to differentiate that, that makes a lot of sense here. Number one. Number two, yes, less than 2 years, any child following a brief episode of viral illness comes with you. It is first time, unless proved otherwise, it is a bronchiolitis. But if a child who's continued to develop, one has to become alert why this child is going on. So usually in that age, if it continues, then one has to be alert in the sense whether what I treated was a really bronchiolitis or something else. That is number one. Number two, is that bronchiolitis going for complication? That is number two. Number three is whether am I missing asthma? So this three, so she has given a very good account of it. Really, you can see that it has been made very simple now. There is a definitive criteria. We used to call asthma qualifiers. Now it has been made very simple. If you are good at ruling out other causes, invariably you can hook on to the diagnosis. That is third thing. So in this case, the previous consultant, what has been seen, I would feel their way of thinking and their way of managing this case, probably there is the important aspect is history taking, a good clinical examination made the differences. And all the more if a child age is less than 5 years. Because as I said, most of the time the parents say that, and every respiratory noise is not a wheeze. Every respiratory noise is not a wheeze, and don't take it lightly that it is following a illness. So these three things, anyone who meticulously does a good history taking, a meticulous examination, and differentiating these respiratory noises, that makes a lot of difference. So when you do that, probably if you are auscultating, getting the history itself, I told, whether it was a any type of noises. So we should be aware about all types of respiratory noise. So, and examination, most of the time, these sounds, those added sounds, whether it is rattling sound, whether it is conducted sound, whether it is a really ronchi, these three sounds invariably they are considered as all ronchi or V's. So that one has to clarify, and those things makes a lot of sense in diagnosing. So probably we have to see that, and moment if it is a localized sign, I would say it would have been a monophonic wheeze, or it would have been either a biphasic stridor. These two things are mistaken in this particular case, and that's why it has been treated as asthma. I think there where we are now, probably we will see how the our consultant has taken it forward. Over to Priyanka.
Thank you, sir. So these were our differentials at that point. While a preschool visa was always thought of, we did think, child had a superadded infection. Was there a persistent collapse consolidation, which is more localized to the right? That's the reason why we're seeing localized finding. Another possibility is a foreign body aspiration. Child is still a toddler. They are still explorative. They're putting everything in their mouth. This remains a good differential. Possibility of an airway malformation, especially when we know that 1 year back also child has had couple of episodes of wheezing, tracheomalacia or a bronchomalacia, some compression from the extraneous pathways are possibilities. So these, when we went back and reviewed all the images, so this is the first x-ray that was done during the first admission. Here what you can see is a hyperinflation of the right lung zones. You can see that the lobe is hyperinflated. You can see a hyperlucent lung margin overlapping into the mediastinum. Some streaky opacities are there here and there, but the prominent finding is this hyperinflation, a shift of mediastinum towards the other side. That is the most important finding we can have. The next episode also they have done an x-ray. While some of the findings are a little less prominent here, but it's still the right lung fields are hyperinflated. In the middle of now, you have more heterogeneous opacities, which is probably the reason they felt a lot of crackles were heard, but the mediastinal shift still remains. So this was the CT that they have done. When you look at it from a superficial level, it looks quite okay. There's no persistent pneumonia or a consolidation. You're able to trace the airway lumen that looks quite patent all the way to this region. And then we also saw the recon images, right? When you see the recon images on different angles, you see that there is a lot of artifact here, right? Child must have been crying or breathing, or some struggle was there, and that's the reason why at this point you're not exactly, you're seeing a little bit of artifact and motion. You're not able to really see a cutoff. If you still do see with proper attention, the right lung field is much more black, less vascular compared to the other side, which is telling us that this area is hyperinflated and much more than usual, right? So we had a strong suspicion of foreign body. We went ahead and did a bronchoscopy, and this is the video. Lo behold, you're able to see a nice peanut sitting at the entrance of the right main bronchus, right, diagnosing us to have a foreign body. We deepened the sedation in the same setting, grabbed the foreign body with a basket, took it out in two pieces, and the diagnosis were a foreign body aspiration. So, what should we know about foreign body aspiration in a small, brief 2-3 slides? Right, toddlers are at the highest risk. They have great incisors, can take a good bite, but they don't have good molars at the back to chew this food properly. Some of the younger ones don't have good coordination, and they're constantly keeping their food in the mouth and running around and playing. No matter how much you tell them, they don't have any concept of risk. So, they will explore the world around them by putting it in their mouth. And that is when you can have foreign foreign body aspiration. This is the classic history. You witness an episode of choking, a sudden onset cough, or a breathing difficulty, noises during breathing which did not exist before. An important thing is that even if they've not seen the child put something in their mouth and choke, there should be an access to foreign body. Mother says, I do feed peanuts, but I haven't seen her choking. But the fact that she does feed the child peanuts is an important factor. Sometimes there's an older sibling in play. They're innocent, they're sharing their food with the younger one, and the younger one is choking on this. Classic examination findings, very localized, unilateral findings, a monophonic wheeze, like Dr. Kalpana said, and stridor, which did not exist before. Classic X-ray findings where you have a cutoff of the trachea, entire collapse of that lung, the whole mediastinum is moved, and you can easily pick up foreign bodies. Not every time is it very apparent. Some of the times it can be atypical. You can get a child who comes with a acute life-threatening episode which is just not explained. We've seen children who come with multiple hypoxic seizures. This was a mobile foreign body which is moving. So the child is coughing, it hits the glottis, child goes into a spasm, then collapses with a seizure due to hypoxia. Air leak is a possibility. When it's completely occluded, eventually because of back pressure, you can have a pneumothorax, subcutaneous emphysema. Voice change and a drooling is also expected if the foreign body is sitting at the glottis and not allowing the vocal cords to close properly, right? So this was an X-ray we had seen where there is an air leak. In chronic cases, you can also see bronchiectasis, where a missed foreign body has sat for a long time, caused repeated infections, and destroyed the lung. The granulation tissue it is produced can give hemoptysis, a recurrent pneumonia, a recurrent wheeze that does not get better, and sometimes a lobar collapse or consolidation that might not have a clinical correlate. You should still think of a missed foreign body. Diagnosis is possible. Chest X-ray is a good modality, but we should be aware but that in 30% cases, it can still be missed. A chest CT can help you pick up, even if the foreign body is radio opaque or not, you should still be able to see signs of the foreign body aspiration in the CT. And a bronch will be a gold standard diagnosis as well as a therapeutic modality. I will not go into the details, but what we should know is that foreign body can be removed in multiple ways, either by rigid or flexible or even hybrid techniques are possible. But the way forward is flexible bronchoscopy because it can help you diagnose and take it out at the same setting. It gives you a reach to distal segments. You can pick up the most smallest foreign bodies which crumble and get inside. It allows you flexibility in sedation. You can take it up in your bronch suite, in your ICU or the OT, wherever you would like it. It allows you complete airway survey, and overall it's a much less invasive procedure, faster recovery, and you can cut down the cost for the patient. Now with improved technology, we have so many tools including cryotherapy that can help us successfully retrieve these foreign bodies. So our take home message should be this: if you have a young toddler, unilateral or localized findings, do think of a foreign body. Just because there's no aspiration history does not mean that it cannot be possible. Chest X-ray has its fallacies. You should know that in some cases you can miss it unless you have a high degree of suspicion. The diagnosis should be with flexible bronchoscopy to find and flexible bronchoscopy to retrieve. That should be our way forward, and we should not be delaying bronchoscopy in interest of giving them a trial of antibiotics and waiting, because the longer it sits inside, the more the damage that is there to the lung as well as to the airway. That's the first case. Any comments, sir? Any closing comments?
Very well presented. What is important is to suspect foreign body, particularly in the age group that you discussed. Sometimes a child may not have these classical signs that you put in your X-ray, and it could be useful to take an inspiratory film and an expiratory film, because subtle airway hyperinflation can be missed when it is a mid inspiratory expiratory film. So one film on inspiration, one film on expiration makes the difference. In a 2-year-old, that may be difficult. So what you can do is to compress the diaphragm. That will give you an expiratory film, and then you take an inspiratory film. That's number one. And then there are certain foreign bodies which you may miss. I remember Professor Sukumaran presenting a foreign body of a X-ray piece, and that was retrieved only by bronchoscopy. So that's possible. Fifth, even if you remove this vegetable foreign body, which has been there for quite some time, these children may have symptoms for around 3 months, because particularly peanut foreign body and areca nut foreign body, they tend to create a chemical reaction around the site of lodging, and that takes quite some time to respond, and that's something you should share with the parents. Otherwise, once you remove the foreign body, they expect a magical recovery, which may not happen. The child may still be coughing. So these are my take home points.
I think Priyanka, really very good presentation. The issue is every one of us should not miss the basics. So invariably, if you are not taken a good history, not examined properly, then not asking for a relevant investigation. So you should know what you have to see in X-ray. So you should have been anticipated after the examination. So that will give a lot of information when you look at the X-ray. Otherwise, X-ray doesn't tell you everything, because back of mind, you have a good history. Yes, this is what is anticipating. And otherwise, invariably it misses. So good history, examination, and relevant investigation interpretation. That is very important. And if you see this case, this tells us that there was no good attempt to taking history. Probably, I'm not blaming anybody, but this is the fact. That is number one. Number two, I will tell you, a foreign body can mimic like asthma if it is a mobile foreign body, and if it is a very small foreign body. If it is a multiple foreign body, exactly it mimics like an asthma. Okay, that is number two. Number three, wherein a child of asthma, if he has aspirated foreign body, then he fits very well into the your GINA guidelines. He will dramatically respond, he will show good improvement, and he will be playful. He will not have any failure to thrive or any features. But the child on after that, even the examination air entry will also be good. So I have seen couple of cases wherein multiple foreign bodies. So when I retrieve, then I'll see distally one more is there. And I have seen another foreign body in the another bronchus. So this type of multiple foreign bodies, it's very difficult to see that whether it is a monophonic wheeze or polyphonic wheeze. A wheeze is localized or generalized. In such situation, we can miss. But a classical case like this, I feel we should be more meticulous in interpreting the X-ray. X-ray is right from one. It is very obvious, and this should not be missed in clinical practice, and definitely everywhere there is a clue, and this is how one has to examine. So high index of suspicion came is when examination findings are localized. The moment localized, you should think it is not a systemic disease, it is a local disease. So what is local? Whether it is a intraluminal, luminal, extraluminal, or whether it is unilateral, whether it is only one lobe or one segment. So many things comes to your mind, then you can make a precision decision to investigate that particular child. So in this case, probably that has been done, and I think the take home message from this case is not all wheezes are asthma, and we need to look into it, and it all depends upon how the child present, how examination clinical findings, and what investigation tells us. That matters a lot. Thank you, Dr. Priyanka.
Thank you, sir. I think I'll pass it on to Dr. Shruti for the next case.
Pooja, have you introduced her?
Yeah, both have been introduced.
Yeah, then can go on.
As she is presenting, I just have a take home message, and that is, we all say asthma is a clinical diagnosis. Chest X-ray is not necessary to diagnose asthma. But this is one typical case where chest X-ray was useful because this is a atypical wheeze. So you should know when to use the investigation. Thank you.
Thank you, sir. So, can I begin?
Yeah, go ahead, Dr. Shruti, please.
Yeah, a very good evening to all the esteemed dignitaries present here. And at the outset, I would like to thank the
Shruti,
Dr.
your
Shruti,
voice is not heard. You can put the
voice is
video off.
breaking.
Karnataka and the respiratory chapter. Without much, sir, are you
You
able
can
to
put
hear
your
now?
video off, Shruti. Yeah,
Huh.
if you
Yes.
want. Yeah, because data is a bit weak.
Okay, sir, just a second. So can you see the screen?
Yeah, please make it full screen, ma'am.
Yes, sir, I've done
Yeah.
it. Yes. So, without further delay, I'd like to move to my first case. It's an 11-year-old boy who presented with the complaints of cough and cold for last 1 week, fever for the last 2 days, and some shortness of breath for the last 1 day. Now, this child had a significant past history wherein his symptoms started somewhere at around 6 years of age. He's been to multiple doctors, which included the ENT for some nasal itching and running nose, which was there all throughout the year. There was no sneezing as such and no ear infections. The child had a multiple X-ray of the paranasal sinuses. There he was diagnosed as chronic allergic rhinosinusitis and was put on a treatment of inhale on the intranasal steroids, SOS, xylometazoline nasal sprays, as well as the Sunile sprays. Now, with the pediatrician visits, he's been predominantly for a recurrent wet cough, some fast breathing. Although there was no documented wheeze, there was never an X-ray with him, and as by the history, there was no particular triggers. He was told that he has got some hyperreactive airway disease, some allergies, which would probably go as the age. As he grows older, he was treated with an on and off nebulizations and some antibiotics, but inhalers were never started. Now, of late, in the last 8 months, he's been multiple times to an orthopedic surgeon for a swelling and pain in the right knee joint. This was also associated with some low-grade fever, but however, this was not documented. There was no history of any rash or any other joint involvement. Workup was done for which ANA, rheumatoid factor, and anti-CCP were done, which were all negative. A ESR of 30 was documented. MRI knee was done, which was suggestive of some medial meniscal tear. There was no history of any trauma as though. He was put on some physiotherapy as well as the NSAIDs. Now, moving to the family history, he's a product of third degree consanguineous marriage. Father expired about 3 years ago. There was some history of wheezing and cough which the father suffered. He was also a smoker. There was no history of any contact. Birth history was not very significant. Now, currently, we have a child who's got some chronic wet cough. He's got some baseline symptoms. He's been on and off nebulizations, and he's got recurrent shortness of breath. Wheezing, plus or minus, we really do not know because there was no documented wheeze. There was rhinosinusitis and some joint issues. Now, of late, the child has been having some exercise intolerance, which is there for the last 2 years. Now, at this point in time, I would like to also mention that during this orthopedic visits that the child had, for the mother, it was a major concern, and the joint symptom was quite a major concern. So, during this time, the ENT as well as the pediatrician visits came down. It was not because the symptoms had come down, the child still had these symptoms, but was managed on some home remedies and some over the counter drugs. Now, when the child came to me, he had a slight tachypnea and tachycardia. There was an audible wheeze, although the child was maintaining saturations at room air. The weight and height were at the third centile. There was a clubbing, which was grade 2. There was bilateral inferior turbinate hypertrophy. Tonsils were grade 1, and the ears had bilateral wax. The chest was having bilateral wheeze and crepitations, especially on the right side more than the left. The first X-ray which was done, it was showing some bilateral hyperinflation. We can make out some right middle lobe infiltrates were also seen. So at this point in time, I would like to stop, and I would request the experts for their comments.
Thank you. There are a few points that all of us would have noticed. Point number one, this child started with symptoms at the age of 6. That to me is a little unusual. Children generally develop wheezing, but to start off wheezing at the age of 6 is something that is not commonly seen, though the father also had some respiratory symptoms. Number two, and very relevant, is this child had wet cough. Children who have asthma do not have wet cough unless they have a very not very usual condition called hypersecretory asthma, where wet cough is there only during the episodes and thereafter they don't have it. Simple reason is that the wet cough clears after the episode. So the wet cough to me is something that is very unusual. The third thing that in history which makes it relevant is that the recent onset exercise induced breathlessness. You have to differentiate the breathlessness which is caused by asthma as compared to those which is not caused by asthma. The rule in children who have asthma is activity followed by breathlessness and relief with rest. But if you have anything else other than asthma, exercise itself causes breathlessness, and then as soon as they start taking rest, it gets better. So this is very common when you have a cardiovascular compromise. The third point is the orthopedic visits. Now, I am just thinking, what is it that connects all three? You have a child who has got a respiratory illness, atypical. You have got a child who has got wet cough. You have got a child who has exercise-induced breathlessness, not very typical of children we see with asthma. And then you have a child who has got clubbing. So what is it that connects all these systems plus the orthopedic issue? The point that comes to my mind are three things. One is collagen connects tissues, vascular structures connects one tissue with the other. And so my answer could be in any one of these, and that is what I would focus on. And for the practicing pediatrician, I'm sure they would remember that clubbing is not a sign of asthma. And here you have a child who has got grade 2 clubbing. So any child who has got a grade 2 clubbing is anything other than asthma. Over to Professor Kalapanavan.
Thank you, sir. See, very important thing has been already told by sir. Most important thing here is whether it is a respiratory problem alone or is it a systemic disease manifesting as a respiratory problem. Okay. And on top of that, here it is a wet cough going on for months. Wet cough going on for months. Failure to thrive. Clubbing, and in addition to this, a child has got other lesions. It may be joint lesions, it may be skin lesions. Okay. So what is important here is probably this child has got a predominantly respiratory manifestation. Can you go back to the first slide? So surprising is onset at the age of, see, look at next, what is her age?
Currently, the child is 11 years, sir.
Yeah, so look at that. So last 5 years going on, okay? So last 5 years going on, already developed this. So we'll have to think of probably it is a suppurative lung disease, okay? And what are the suppurative lung diseases which will have a systemic manifestation apart from that? So those conditions will strike us first. So that is the reason we should ask that history. And the suppurative lung diseases starting with, if it is only for 4 weeks, yes, I agree. But if it continues that, if you don't identify at that level, it can go for a classical suppurative lung disease, PBB, that is protracted bacterial bronchitis. So one has to make sure that, but it doesn't affect the growth of the child. All other features can be there and it doesn't have any other systemic manifestation. Number two, what other suppurative lung disease we can have is cystic fibrosis. Yes, cystic fibrosis can manifest, it can manifest multi-system, it can manifest only the pulmonary system, and it can be silent for a couple of years and then later also they can manifest. So that another possibility is thing. What other possibility we should think is, in this case, we should have asked other manifestation. Does this child has got any other system involvement like otitis media, skin lesions, gastrointestinal or genitourinary? Is there any other multiple infections? That history we should elicit. If they are not there, because those are the things which will be having a child who can manifest with a combined variable immunodeficiency. They can manifest like this. And the third important thing is, why not it is a simple PCD, primary ciliary dyskinesia. They can manifest mainly the respiratory, but invariably they will have neonatal history and then followed by otitis media, then recurrent respiratory infection. So these are very four common conditions which will have a suppurative lung disease, and in them especially a combined variable immunodeficiency and or cell mediated immunodeficiency and PCD and cystic fibrosis, they will have failure to thrive. Rest all other features are there in this child. Clubbing is there, failure to thrive is there, and bilateral involvement is there. And this child has been repeatedly and going on for chronicity. So these four important entities should strike to us when we get a chronic case which is going for already long standing and the child is developing clubbing and failure to thrive, we should think. And among immunodeficiency, if it is cell mediated, then it will have a failure to thrive. If it is only B cell mediated, invariably it will not be an failure to thrive in that particular child. So I feel this is probably a systemic manifestation of pulmonary disease. In addition, as sir said, we'll have to think of, because it may be a brief episode. So last 11 years, there is no other history of other system involvement. So usually the evolution of the disease in collagen vascular disease doesn't take 10 years to manifest. It runs in months, maybe maximum a year or two. So entire disease manifestation occurs. But here, no other skin lesions, no other joint problems, no other nodules, no other subcutaneous nodules, nothing was there in this particular child, and child has been treated for a long time. So I feel probably more of suppurative lung disease in this particular case.
Now, to just add on to what Professor Kalappanavar said, this child has got both an upper and a lower airway involvement. This child has got a chronic rhinosinusitis as well as a lower airway involvement. One of the points which may not fit into the classical PCD presentation is the time of onset of the symptoms. Generally, it is said that PCD starts off quite early in infancy, and then they usually present more with ear issues, and this child did not have ear issues. So I would keep PCD a little lower in the my differentials. I would probably think of a vasculitis sort of presentation, slowly progressive vasculitis. The reason being upper airway involvement, lower airway involvement, being breathless on exertion, plus the presence of clubbing, plus or minus orthopedic involvement. So I would keep that high in my differentials.
Thank you, sir. Moving on, the broad differentials, like probably was it a poorly controlled childhood asthma with some allergic chronic rhinosinusitis with a right middle lobe syndrome, because the child was having a lot of crackles on the right more than the left. Childhood asthma with some ABPA, was it a chronic suppurative lung disease? Or is it a chronic systemic inflammatory disease with a lung manifestation? And lastly, being a primary immunodeficiency. The next investigation we went ahead was with a CT scan. Now, a CTE chest was done, which was suggestive of a lot of tree in bud appearance, which is indicating an active airway, a small airway infection with some mucus plugging. We can also make out bronchiectatic changes which are present in the bilateral lower lobes as well as in the right middle lobe. So, the further workup was done, wherein a PID panel was sent. The immunoglobulins were normal. T cell subset as well as the DHR was negative. A sputum was sent because the child was complaining of the recurrent wet cough. So, for a gene expert TB as well as a culture which turned out to be negative. A PFT which was done, although a poor effort, with FEV1 as well as FVC were decreased, but there was a good bronchodilator reversibility. Bronchoscopy was planned, but that was again deferred due to certain affordability issues. We had a whole exome sequencing done on this child, which was suggestive of a primary ciliary dyskinesia with bilateral. We had two heterozygous mutations here, and thereafter the child was put on some antibiotics, and alternate day azithromycin prophylaxis was started with ICS as well as chest physiotherapy with 3% hypertonic saline nebulizations, and the child improved with due course of treatment. Now, in all this, what actually happened was the child lost about 8 months of his other treatments because of this unusual history that the child came up with as a right knee joint swelling. Now, that actually he changed his the very probably the very thought process of all of us thinking some systemic it is either a systemic disease having some pulmonary manifestation, and the child actually the mother actually he paid so much of importance to that right knee joint swelling, which had actually he developed in that last 6 months, which although improved with time and with some physiotherapies as well as with the NACIDs, is the visit to probably a pediatrician or to a pulmonologist was quite delayed. So just a few slides on the primary ciliary dyskinesia, which is a genetic disorder, which is autosomal recessive most of the times, although sometimes we can even have an X-linked and very rarely an autosomal dominant. It is because of the impaired mucociliary clearance, and it is affecting the upper airways in the form of chronic rhinosinusitis, recurrent otitis media. Lower airways, the children tend to present with the neonatal respiratory distress, as already sir mentioned, and chronic wet cough and progressive bronchiectasis. Situs inversus is usually seen in about 50% of cases, that is a cartilaginous syndrome. And moving on to the Spicada scoring, which we have a clinical tool for the primary ciliary dyskinesia, wherein the baseline is to start with the Picada scoring. We need to have a daily wet cough, which has started quite early in the childhood. The criteria in this are the child is a full term. We give a score of 2. A child who has got symptoms at the neonatal period, which include any tachypnea, cough, pneumonias, another score of 2 is given, and admission in the NICU, a score of 2 is given, and situs inversus a score of 4, or with a congenital heart disease, a score of 2, persistent perennial rhinitis or chronic ear infections, a score of 1 each is given. And put together, any score of 5 is indicating a high likelihood of PCD and strongly warrant definitive testing. A multidisciplinary protocols basically for the diagnosis is it's always a combination of tests, because we know that 70% of us is identified by the genetics. The rest we can use a nasal NO or a high speed video microanalysis. As far as the management is concerned, it's the airway clearance therapy as well as the targeted pathogenic surveillance. So the take home points are always look for the red flag signs. As in this child, we had a chronic wet cough. There was failure to thrive, clubbing. The interval symptoms were still persisting, year-round rhinitis. Any wet cough which is greater than 4 weeks should definitely be investigated. Poor response to asthma therapy is a clue to look for the alternative diagnosis. Look for systemic clues like situs inversus, laterality defects, chronic otitis media. Early Early diagnosis can prevent the lung damage. Airway clearance with prompt antibiotics, vaccination will all prevent bronchiectasis in the due course. So, do you want to give any closing remarks?
To add on to what you said,
Yes, sir.
one is the red flags here are the chronic wet cough. Number two is clubbing.
Yes.
The other point is, which is a learning lesson to all of us, including me, that the classical presentation of PCD may not be followed in every child.
Hmm.
And the importance of genetics, which is coming up of late, will help us to pick up these unusual cases. And probably, had this child been picked up, the extent of bronchiectasis that this child now has could have reduced with early intervention.
True, sir.
And the absence of dextrocardia does not rule out the possibility of primary ciliary decline.
Correct, sir.
Professor Kadapanawar, sir.
Yes, sir. Sir, you are true, and I'll just share my experience. In our institute, now we are publishing. It has been accepted for publication. Total 10 cases of PCD. So we have even to the extent challenged the Picada scoring. In the sense, we have seen as early as diagnosed a 28 days old baby with a PCD, wherein your other criteria doesn't qualify, and even the situs inversus was not there. From there to a child who is 6-year-old who did not had all the features of classical. So the still there is lot of genetic changes are taking place. The PCD, even in your case also, if you remember correctly, it is uncertain significance. It means it is there, but there are no cases reported in that. So your case is classically fitting into all these criteria. You can report this, and later the registry entry will happen with this genetic changes. So lot many different presentations are there in PCD, and we should not only stick on to the Picada scoring, and we can start thinking whenever a child whom we think that with the suppurative lung disease or recurrent otitis media or neonatal child who comes with a pneumonia and neonatal distress. So we have to think these conditions. So the PCD can behave in a different manner at a different age and in all types of varied spectrum of presentation. So this is probably one of the way this case has presented to us. Over to you, sir.
I think there was a question on how do you explain the joint involvement. The joint involvement may not have a bearing to this case. It was incidental is what we can explain. Because
Correct,
that
sir.
didn't
It
recur.
actually took away about 8 months of the child because during that time it was when probably she stopped going to all the other doctors, and then she was concentrating just on that joint and then some rest and things like that.
See, the other rule that we used to follow is put all your eggs into one diagnostic basket. But that's the general rule, but sometimes there may be exceptions. So this joint involvement was something that made us deviate.
Correct, sir.
The other issue about the primary immunodeficiency is if you have a B cell immunodeficiency, generally they present after the age of 9 months when the maternal immunoglobulin comes down. And most of them develop infections elsewhere also. This child did not. So that was one point which didn't fit into primary immunodeficiency disease. Something occurring after the age of 6 is a little unusual, except for syndromes like hyper IgE. They may present little later. Thank you.
Thank you, sir. Over to Dr. Priyanka for the second case. So am I audible?
Yeah, you are. Please go ahead.
Uh, is my screen visible? Can I go to the next case?
Yes, but
Not yet. Not yet. She has to stop sharing her screen, Dr. Shruti.
yes, sir. So I've stopped sharing, huh?
Yeah. You please,
Yeah.
you go ahead, ma.
Right. Sure. So the second case is an 11-month-old boy. Now he came with recurrent admissions for cough and breathing difficulties since 2 months of age. So that's a very early onset. So he was born to a third-degree consanguineous marriage. The father was a bronchial asthma on MDI taking regularly. They had 3 children. The first child was a 5-year-old girl, school-going, well child with no other issues. They had an abortion in between the two live kids in the first trimester. Spontaneous abortion with no other reason was not evaluated further. And the third child was our index child. So our 11-month-old boy was born as a term delivery at 3.3 kilo, born to a gestational diabetes mother. So he was admitted in the NICU for 2 days for TTNB, which is expected for a term delivery with the GDM was possible. He was put on CPAP for 1 day and then he recovered quickly enough. Now the first episode of illness happened at 2 months of age. So there was a family event, some gathering where everyone is picked up and played with the child, after which the child developed cold, cough, and fever that lasted for 5 days. Progressively, the breathing difficulty became worse and worse. He ended up in the PICU with HFNC for 4 days and was treated as bronchiolitis. Took a long time. So that's a long stay of 9 days in the hospital, after which he was discharged. Mother says for first 6 weeks after the first episode, he was okay, he was doing well. Second episode happened at 4 months of age. Similar cold cough, one episode of low grade fever, breathing difficulty. Wheeze was noted and documented, and he was treated on OP basis with a bout of antibiotics as well as nebulizations. Now, after this, he's had 4 other episodes. Every month, he's had an episode of cold cough, fever, plus or minus, and breathing difficulty. Some of these episodes were triggered by a viral infection concurrently present in the older sibling. Most of these episodes had a night cough. Child would cry and then end up coughing and vomiting. Mother started noticing towards the end an audible wheezing, and she did say that towards the end of presentation, the clearance between episode was very poor. It was almost sort of a lingering cough that persisted between episode to episode. How was he treated in these episodes? So one more episode of IP admission was there. Every episode, he needed not only nebulizations but oral corticosteroids at a dose of 1 to 1.5 mg per kilo per day. At least for about 4 or 5 days, he was given every episode. Every time he received antibiotics, either an amoxiclav or azithromycin was given. Eventually, they even tried 2 weeks trial of a PPI with domperidone, thinking of a reflux-related chronic aspiration. He did not respond, and finally they put him on MDI Budacort 100, 2 puff twice daily. For a child who's 11-month old, this is a moderate dose and a quite stiff dose. It was taken for 5 months continuously, diligently, in the right technique, at the right dose, in the right manner. Despite everything, he progressively worsened with no or poor response to medications. Eventually, his weight also stagnated, despite the fact that child was eating well and was being fed good nutrition. Right? When you look at the history, these are all negative histories that we picked up. There was no atopy, there was no eczema, there was no prolonged jaundice at the neonatal time. The meconium was passed on day one. There was no salty kiss or bulky oily stools, no persistent nasal symptoms, no diarrhea, rashes, oral candidiasis, and no aspiration of feeding difficulty or coughing with feeds. So these are all prominent history I think of, especially when a child so young is coming with many episodes of recurrent wheezing. When I examined the child for the first time, his weight was poor, failure to thrive. He was tachypnic. Mother, in fact, said that he was between episodes, meaning that this was normal interval. Despite that, I saw a saturation of 83% on both sides. He had bilateral ronchi and fine. So these were all the red flag signs that we picked up. Child had an early onset symptomatic period. There was a neonatal. Interestingly, the antibiotics, but corticosteroids were given. The episode, he did not have interval clearance, failure to thrive, normal examination. So these are all the what differentials I start thinking, especially when a child so young is wheezing so often. Just like in the previous child, neonatal onset PCD is possible, cystic fibrosis is possible. Though nasal symptoms are not given as a history very easily, not many mothers complain and come up with this finding of nasal issues in such a young child. Primary immunodeficiency is a possibility here. Just like our professors said, maybe not a B cell deficiency, but a combined immunodeficiency or a T cell deficiency is possible, right? Chronic aspiration due to any abnormality, either a H-type fistula that has not been picked up, or an airway abnormality, an airway malformation, or a post-infectious bronchiolitis obliterans. A young child with infection, lung has gotten damaged. Right? These were my differentials, sir. If you would like to add anything to this, Professor.
Now, yeah, I think it's a very good case that you are presenting. What strikes in this case is the early involvement of this child's symptoms from the age of 2 months. And therefore, asthma is very low in the list. Number two, if you look at the presentation is with only airway symptoms. This child has had cough which did not respond satisfactorily to bronchodilators, and that is something that makes asthma a little unlikely. What one of the possibilities could be that this child could have had a significant airway malacia, and each episode of an infection, usually a viral trigger. If this child has a significant malacia, then these children take a long time to respond. They don't respond satisfactorily to bronchodilators. Some of them may respond to ipratropium, and there could be an audible wheeze which is mistaken by the mother. And the other point is that this child is not showing response to the 200 micrograms twice daily of budesonide. That makes me think that this child is not having the usual chronic eosinophilic airway disease, which we usually expect in children who develop wheezing episodes at such an young age. High on my list is an airway malacia, which could be both tracheobronchomalacia. The only point that I am not able to fit in is that many of these children with malacia syndromes do thrive well. And here you have a child who is not thriving well. And children who have airway malasias also can have the other vetral anomalies. So these children can also have a significant gastroesophageal reflux, which was treated, but I do not know whether this child was investigated for reflux. To me, the red flag signs are early onset, recurrent episodes, unsatisfactory response to the usually used bronchodilators, and no response to a good dose of inhaled budesonide and failure to thrive. So that is where I would stop and request Professor Kalapanavar to take over.
Thank you, sir. Very important aspect is any child whom has been treated as a bronchiolitis and subsequently child is coming with a similar episodes, one has to become alert. So what can happen? A child who just recovers again develops a similar episode, and again he recovers, again he develops. This is a one classical pattern. In the case of bronchiolitis, we should think of, is this child going for post-infectious bronchiolitis obliterans? This is a very common entity. You should think, especially in the last year, the epidemic which was going around. That's number one. Number two, the child who is not responding to conventional your asthma treatment, but presents like an asthma. The clinical features looks like asthma. There will be a classical wheeze, tachypnea, desaturation, and child will be there in intensive care unit for a couple of days and slowly recovers, but it will not recover completely. So this is another entity, and some children, they will have an episode of bronchiolitis they recover couple of days, and again they start slowly deteriorating. So there are 3 4 nature of presentation can happen with a bronchiolitis obliterans, and some of them can come with what is known as BOOP, bronchiolitis obliterans organic pneumonia, wherein child presents with a very severe episode of wheezing, tachypnea, and will not respond to our routine management, and invariably might require some type assisted ventilation. So these can happen like this, and this is a very in a case like this, one has to think of it. As sir said, yes, definitely a child who has got, you know, the other symptoms are there, then you can think of other differential. So she has put all the other differentials, but no other features of differential diagnosis. For example, there was no, the to think of GRD. You don't have a child who is coming with vomiting and cough or wheeze, and sudden onset is not there, and all episodes are recurrent. So that is unlikely, particularly in this case. So my gut feeling is probably this child is heading towards that, or a child who has got a systemic diseases manifesting and deteriorating very fast, especially immune mediated diseases. We'll have to think of those conditions. A child who started manifesting like a bronchiolitis, and there are conditions like, eosinophilic lung disease. It is a good chunk of lung disease wherein they start with like a bronchiolitis, and they doesn't respond to our routine management, they deteriorate. That is another entity. The third entity is hypersensitivity pneumonitis, and this is also mimics just like asthma, but every episode is worsening, and there will be a good environmental history exposure will be there. So in such situation, we should ask an environmental history in these conditions. So my ouch in this case is, among these three, probably one is fitting when it is not fitting well into the GINA guidelines requirement of asthma. This is over to you, ma'am.
Thank you, sir. So I think we have had a good understanding of why these differential exists, and again why these differentials don't exactly fit. Though this is the order in which we have to look at in a child who comes this young with so many episodes of wheezing. So this is where how we went ahead on a workup. Everything was negative, just like the history. Sweat chloride was negative, immunoglobulins, flow cytometry, MDT-DHR, every immunological workup was negative. A bronchoscopy was done, airway malformation was ruled out. Lavage was done, did not show any lipid laden macrophages, which are suggestive of a chronic aspiration. We didn't do a GR or a milk study, but the bronchoscopy was proof enough to us that the airway grossly did not look abnormal. Genetics was also done, and a whole exome panel was completely normal. So, this was the X ray of the child. Diffuse, heterogeneous, patchy opacities, bilateral lung fields, nothing else is obviously seen. And the clincher here was the CT finding. Typical CT finding showing areas of ground glassing, areas of air trapping with mosaic attenuation patterns, where areas alternatively are a little more gray and a little more darker. Some areas having some areas of atelectasis, some small patches of consolidation. Bronchial wall thickening is noted. We're not seeing any bronchiectasis yet. This CT is classical of post-infectious bronchiolitis obliterans, and that was our diagnosis. So what is PIBO in brief, right? So basically it's a chronic obstructive rare lung disease in children that follows a severe viral or another lower respiratory tract infection. There is an epithelial injury, dysregulated repair, subepithelial fibrosis. Eventually there's a fixed obstruction because the whole lumen starts being encroached by the fibrosis. What can cause any severe viral infection? Most commonly adenovirus is the culprit. You can also have measles. Even mycoplasma pneumonia can cause a BO. We've had a case that we've treated last year. Influenza can cause. RSV is likely less likely to cause a BO. Other non-infectious causes like a chronic aspiration, even Steven Johnson syndrome, though rare, can cause a PIBO, right? So the risk factors that should alert us to think of BO is a adenovirus in a child, young age of onset of a severe LRI. The younger the child who's gotten a viral infection, the more the chance that this child can progress to BO. Any child who had a severe event, was mechanically ventilated, took a long time to come out of oxygen in the ICU, or had an extensive radiological involvement, we should think that this child is possible to move towards BO. So these are all the clinical differentiators, as sir was very correct in telling us that a fixed non-reversible airway obstruction which does not respond to your bronchodilators or your regular dose of inhalers like you give for an asthmatic should alert us that this is an irreversible obstruction and therefore not an asthma. You can have flare-ups just like in an asthma. Every time you get a viral infection, you can have worsening, and they responded. In our child, if you remember, every episode they had given oral corticosteroids. So inadvertently, the primary pediatrician was treating each episode, but what was that dose of steroid was not enough to completely take care of the BO in totality. A child who comes with problems which is incomplete recovery between episodes, chronically going on to have symptoms, not a wet cough, but clear, severe wheezing, bilateral fine crackles can also be there as the progression moves towards an organizing phase. And in severe cases, we can also have failure to thrive. So, this is how a PIBO can be diagnosed. A CT should be a classical way to diagnose. A PFT can only tell you that there's a fixed obstructive pattern, but children this young, you don't really have an option to do a PFT properly. All other investigations like bronchoscopy, genetics is only to tell you that you can rule out all other causes if you are unsure of the primary diagnosis. Treatment, I in very brief, just corticosteroids are the cornerstone of therapy. IV methylprednisolone is being considered the standard of care. The dosage is always debated on. We follow a 30 mg per kilo per day for 3 days. We pulse the child and give it monthly. Depending on how the child is doing, we think of 3 cycles, 6 cycles, 9 cycles. Oral prednisolone can be used during exacerbations or to cover between episodes. If they don't do well with IV methylpred, then you can look at second line immunomodulation. Other therapy is if acutely the child is very sick and wheezing, you can give SABA, you can have some response with Levolin or Astelin, but there has been documented studies where tiotropium has been seen to have some response. As a combination, azithromycin, montelukast and budesonide or fluticasone has been given as a combination therapy, which is initially proven for a post transplant BO, which is called post transplant, either a bone marrow transplant or a lung transplant, has been proven to have good efficacy. And PIB also we're seeing overall supportive care, giving them good nutrition so that they don't go into catabolism, some oxygen, BiPAP, vaccination, long term follow up is important. And important to understand that the prognosis is variable. In some, at least 30% cases, especially if you catch them on in a very good window period, they do dramatically well and they can be good without steroids. But 30% can progressively worsen and eventually even need lung transplant. So a window is important to understand. So if a child who has regular red flags like what we saw in our case, where every episode of these you're needing oral corticosteroid, that's not a good thing. We should start thinking beyond asthma. History is our sharpest tool here because no other blood test will tell you if there's a PIB or not. A fixed obstruction, as sir said, is a clear divider between asthma and POBO, and ruling out mimics is important before you declare them to have PIBO. And a window is very important to recognize. If we sit waiting saying this episode we will treat with little bit of steroid and let's see what's happened in the next episode, child will keep going on towards fibrosis and very hard to reverse back. Thank you. So the next case, sir, any closing comment, sir?
No, I think very well presented. The take home points would be that what starts off early is not asthma. Number two, as you very rightly pointed out, the airways are very tender in the first 3 months of postnatal life. So a very severe insult to the airway can cause consequences, and that is very evident in this child. And as you rightly pointed out, azithromycin was given, oral corticosteroids were given. So that made the child get better for a while, and that probably prolonged the diagnostic criteria. Otherwise, had they not used it frequently and questioned themselves as to should we use oral corticosteroids every episode, the answer could have been got. And this is probably a new entity that is coming up, which all of us have to be aware. When a child does not behave the way it does for the acute episode of bronchiolitis, think of PIB. And failure to thrive is a additional aspect because this child is spending all his time breathing away. So failure to thrive is something that is not usually seen following a acute viral illness in other children. Thank you.
Thank you, sir.
Priyanka, from where this case has come to you?
I shouldn't say,
You
sir.
shouldn't. No, place you can tell, no?
From Anantpur, sir.
Okay. No, I had a similar case. I thought that case has come to you because I referred to the pulmonologist and I thought, wait, afterwards I lost the case. So I was thinking, it's similar way, exactly. Almost 5 admissions from the age of 4 months. And he came to me at the age of 1 year. And when I saw the x-rays and everything, immediately I thought it is not my case. It belongs to a pulmonologist. I referred to the pulmonologist. So he went to, where, I don't know where else he went. After that, I lost the case. I thought that case has come to you. Okay. So similar case, exactly similar. When you start presenting the case, I thought it is my case only.
This child was treated in Anantapur by the pediatrician
Okay.
for a while.
No,
and came to me in intervals.
Okay. Fine. Good. I think if Kalapa sir, Kalapa?
No,
sir.
I
Ashwati
think
can
he
go
is
ahead.
left. He is left. He's got to attend another meeting. So he has excused himself.
Yeah. So, you can go now. The second case from...
Yes, sir. Can you see the slides, sir?
Yeah.
Yes, sir.
Please go ahead.
So, moving on to the second case, it's a 17-month-old boy who actually presented with recurrent admissions for cough and breathing difficulty and wheezing since the age of 6 months, since the age of 5 months. Now, as it is started quite early, I would like to start with the birth history and the family history. This child is a is born out of a third-degree consanguineous marriage. There is a strong family history wherein both the parents are known case of bronchial asthma. Both of them are on the MDI. This child was a term delivery with a good weight, with no NICU stay. The only thing was the child had a severe cradle cap in the neonatal period. Now, the child had his first episode at the age of 5 months, wherein the child had this cold, cough, and fever for 5 days and breathing difficulty. So he was admitted for some oxygen as well as treated with nebulizations, predominantly treated like a viral bronchiolitis. He had another episode at 6 months of age, again 1 month later, that is again with the similar complaints of cough, shortness of breath, and wheezing for 2 days. Now, this time he was admitted in the PICU, wherein he required HFNC for about the next 3 days. He was given some nebulizations, steroids, and antibiotics, and the supportive care. Now, there were subtle symptoms between the episodes. That is, the episode first started at 5 months, and in between also there were few symptoms noted. Some occasion, some cough, some baseline tachypnea was still present. Now, the child actually had a good weight gain, although the chest X-ray done at that time was just suggestive of bilateral hyperinflation. Now, in the subsequent course, the child had another admission in the next 15 days itself, around 6.5 months, with cough and fast breathing. There was no fever this time. There was some history of regurgitation of feeds. There was a lot of arching, and thinking of some GERD, the child was started on anti-reflux therapy empirically. A 2D echo was done at this stage, which was normal. Now, similar such episodes happen again, and another 3 episodes. These episodes were only needing an OP visit, wherein the child had some cough and shortness of breath and wheezing too. Now, in view of a strong family history, the child was started on MDI budesonide. At the same time, a CT chest was also done, which was reported normal. Now, despite the child being on inhalers and anti-reflux, the child continued to have multiple visits of cough, and wheezing. Now the weight started. There was no adequate weight gain. Now the weight has almost become a little stagnant. Each episode was triggered by some URI. So this is a CT which is fairly looking normal. We can see the airways and the lung parenchyma, which all look quite normal. Now, the broad differentials here were our recurrent aspirations due to GERD, some mucociliary disorders like a cystic fibrosis. Are we dealing with any airway anomalies, or is it a primary immunodeficiency disorder? At this point, I would like to stop. I'd like to request Nagbhushan sir for his expert opinion.
Yeah, I think the important things about this child is that this child, the infant developed symptoms very early in the child's age, fifth month onwards, and these episodes have been very recurrent as compared to a child whom we usually see, infant whom we usually see. We don't see a infant coming to us every month or once in 15 days with viral episodes. The classical involvement is the airway, because at times the child had fever, but at times the child did not have fever. He had cough and fast breathing. So it was the airway that was primarily involved. What involved the airway, whether it was a viral trigger or something else, is something that we need to look at. The important thing is that this child was thriving well. Once the child is thriving well, the possibility of the other differentials that we thought of are a little less likely. There is one history of regurgitation of feeds with arching. That is something that I wouldn't want to neglect, because this child has a airway problem and this child has something suggestive of a gastroesophageal reflux disease. So that brings into focus the cough and fast breathing without fever episodes, because when you have episodes of GERD, they don't manifest with cough and the symptoms are usually around the time of feeding and then it starts out. The only other point which sometimes happen is this hypersensitivity pneumonitis, because many times these children, when they are weaned, they some of these children are little hypersensitive to particular dal sort of feeds, particularly the moong dal. And when the mother feeds it and there is a regurgitation and the child gets unusual, but to be kept in mind. The fact that this child had a strong family history does not mean that this child also has asthma, because the way this child has presented is not like asthma. And number two, the response of the child to the inhaled budesonide is also not satisfactory. So I would keep airway malicious, I would keep gastroesophageal reflux high on my differentials, and also investigate for other causes. The other issue is this child is getting to have HFNC at multiple episodes, which is not very common in a child who presents with a viral respiratory illness. So there may be something in the background that is making this child to decompensate so very fast. So airway anomalies, reflux is what I would keep in mind. Airway anomalies down and reflux. When you have a reflux, I would also want to know the type of feeding this child has, because many times children who are bottle fed, particularly if they are fed in the lying down position, these children are likely to have reflux much more than children who are not bottle fed or who are not bottle fed in the sitting up posture. So that is one thing that I would focus on. And a reflux can be macro reflux, it could be a micro reflux, or it could be just a reflux bronchospasm that can involve the airways. So I would consider the possibility of a micro reflux here, where though the classical features may not be there, but this child could have a reflux that is causing the respiratory symptoms. The viral triggers may exacerbate this, is what is my opinion. Thank you.
Thank you, sir. Moving on further, in the current admission, the child was quite having a lot of tachycardia. There was tachypnea with mild intercostal and subcostal retractions. The saturations at room air were about 95%. The chest revealed bilateral V's and crepitations. CBP, which was fairly normal with, I can say, a mild anemia, 10 grams of hemoglobin with a total leukocyte count of 4,100. The CRP was mildly elevated of 22.3 milligrams per deciliter. The chest X-ray revealed bilateral hyperinflation with some subsegmental collapses, especially involving the lower lobes. Now, as we know, as rightly said by Sir, that the child, we cannot neglect the fact that the child was regurgitating. The child was actually on a mixed feeding, both breastfeeding as well as a top feeding. So, an upper GI contrast was planned, a barium swallow study, wherein the grade 1 to 2 reflux was suggestive, which also had a smooth persistent indentation on the posterior aspect of the upper thoracic esophagus. Thereafter, a bronchoscopy was planned. So I'd like to just play the bronchoscopy video. So here we are entering in the trachea. So as we can see, there are a lot of pulsations which are actually seen on the posterior end, as well as a few pulsations are even noted in the anterior. So the airway looks quite narrow. There's some Malasic segment way down. So as we can see there is a little, there are a lot of pulsations even here. So we went ahead and did a CT angiography. So this is the CT of the child. So as we can see here, this is the aorta, and then we see an aberrant right subclavian artery, which is actually coming. And in fact, there is another one, and it is the right brachiocephalic. It is coming and joining in front to the left side. So the interesting thing in this is, firstly, a CT which was done outside, that was a plain CT. So ideally, a child who is young enough, wherein you're thinking of a child having a persistent wheeze, not getting better, always think of some, if you're thinking of a vascular structure causing these problems, a contrast CT would be a better thing. Initially, a plain CT was done, and even in a CT angio, if we see the cross sections, so we cannot really make out any cross airway abnormality on the CT. So even the CT which was shown, now this is the aberrant right subclavian artery which is arising, and for the this is a picture which tells us the aberrant right subclavian artery, which actually goes behind the esophagus most of the times, and in a small percentage, about 10%, and it can traverse in between the trachea and the esophagus. So the glitch here was that the child actually, he had a vascular anomaly, which was not which was picked up on the CT, but even on the CT, we could not really make out that there was any compromise of the airway, and this compromise was picked up on the bronchoscopy, as bronchoscopy is a more a dynamic procedure wherein we can actually see the dynamic compression of the airways. So just broadly, to talk about the different vascular abnormalities, is these are classified as complete vascular rings, incomplete vascular rings, and others. So the complete vascular rings, the most common being the double aortic arch, which presents right in the early age, and the others being the right aortic arch with mirror image branching, and the right aortic arch with an aberrant left subclavian and artery and circumflex aorta. I'll not go into the details of this. So, just a summary on this is that when do you clinically suspect any child who is having a, say, persistent stridor or a refractory wheeze, having a noisy breathing, especially exacerbated by feeding or crying, we need to do a screening. A screening can be done with a chest x-ray. Look for a right-sided aortic arch, which can easily be found on the x-ray, or a tracheal deviation or a narrowing. A barium swallow would tell us, as it's a classic screening tool, which will tell us about any indentations, especially the esophageal indentations, the posterior or anterior, which can tell us what kind of a vascular structure is actually compressing. And the confirmatory would be a CT angio. It is a gold standard for mapping the exact vascular anatomy. The flexible bronchoscopy, as in our case, which was performed, would assess the degree of the dynamic airway compression and also rule out the concurrent malacia. So definitely, it's a multidisciplinary approach wherein a pediatric pulmonologist, a pediatric cardiologist, and the CT surgeon, and a pediatric ENT if there is a complex upper airway air reconstruction if it is required. So the take-home points are: evaluate for all airway anomalies in persistent wheeze, especially if the wheeze is starting very early, it is poorly responsive to bronchodilators, or if it is accompanied by stridor or feeding difficulties. History is always the key. Identify the red flag signs early if there's a wheeze or a persistent stridor, any worsening with feeding or in a supine position. Do not rely solely on a normal imaging, as in our case, the first CT that was a plain CT, it was completely normal, although we could not really appreciate any vascular structures in that as it was a plain CT. Bronchoscopy again will help us in visualize the dynamic compression. So consider bronchoscopy when the diagnosis is uncertain. Monitor the feeding patterns, especially the difficulty in swallowing, any choking, or any cyanosis when the child is feeding. Early surgical correction is definitely the key. So, any closing comments, sir?
I think very well presented. Two or three practical points. Point number one, that if you have the suspicion of a reflux, this reflux could be secondary to a vascular ring or it could be primary. So before going to do a CT angio, it may be worthwhile to do a barium swallow, which can pick up the, or which can suspect, and then you can do the relevant investigation. Many people do the echocardiogram and say the heart is normal, but that's not the test to be done. You have to do a CT angio. That's number two. Number three, esophagus is posterior. So if you have a internal carotid artery, it may compress the esophagus much more than the trachea. So on a plain CT, you might miss out a tracheal compression. Number four, depending on the type of vascular anomaly, presence or absence of stridor is decided. Not all vascular anomalies present with stridor. And the classical history that was presented, that the child arches when lying down. Many children with vascular anomalies generally feel better when they are prone because the vascular anomaly falls forward, or when they are put on supine, then sometimes they have compression and there may be intermittent choking episodes. At that time, there could be an aspiration, and that is why you had right sided signs. The key to correct diagnosis is to suspect. Once you suspect, then investigations will follow, and then you will arrive at the conclusion. CT angio, I do not know, probably MRI, which is difficult to conduct in such a small child, could also throw MRI angio could also throw light. The fact that you brought out that you do a CT, keeping in mind the possibility of a particular diagnostic consideration, and then you will not do a plain CT, but you will do a CT angio. And last not the least, when you have diagnosed one anomaly, please look out for other anomalies in the same child. And that is where the dictum of charge or Waitral matters. Some children may have more than one anomalies. Do not fail to pick them up. Thank you.
Thank you, sir.
Stop sharing, Shruti.
Yes, sir. Yes, sir.
Pooja, can you please take the question in the question box?
One question is there from Kamoji. Have a question at 2 to 6 months. What would be an indication for azithromycin and steroids? I wonder. That too recurrent doses. That's what the Kamoji has commented. Any?
I think this was commented before I had revealed my diagnosis, probably of PIBO. So, what has happened is most of the times when pediatricians or treating clinicians are seeing wheezing and they hear an obvious polyphonic wheeze, which is severe, causing distress, not responding to a nebulization. It's a very trigger finger thing to start steroids and help the child get better. It will momentarily solve all our problems, give clinical relief, and get the child out of the ICU. But the trick is to always think, why am I needing so much of steroids so repeatedly in such a young child? And that is what we should be aware of.
And the point also is that not to inadvertently use azithromycin in such a young age, because you may postpone the diagnosis. Azithromycin is not indicated unless this child has got persistent wheeze, and that is something that we don't see quite often. On my behalf and on behalf of Professor Kalapanavar, we would want to congratulate both the speakers for an excellent selection of cases. Each case brought up a very different mimic. So properly, when you suspect mimics, the way to go is to ask whether the mimic is in the respiratory tree, whether the mimic is in the cardiovascular system, whether the mimic is related to the GI or other systems. And once you narrow down your diagnosis, probably you will arrive at the logical conclusion. Wonderful cases, well presented, and very crisp and to the point. I think we have youngsters coming up in a very promising way.
Thank you, sir.
I think the only thing is to prolong the whole discussion to 11 p.m. if that's the only thing.
Thank you.
It doesn't matter. We enjoyed it.
We enjoyed. It's a really good cases. All the 4 cases were really good. Great. And both the presenters were very clear-cut, confident in presenting the cases. And that is the more important. So that gives a lot of interest in the cases. Thank you a lot, all of you. Fine. Beautiful.
Thank you, sir.
Pooja, you want to close? Yeah.
Thank you. Thank you, Dr. Pooja, and thank you, Dr. Nagbhushan sir and Dr. Kalpana sir, for the wonderful discussions. Thank you, of course, to our young guns, Dr. Priyanka and Dr. Shruti, for accepting and presenting such wonderful cases. And a big thank you to our all our viewers who have stayed with us right until 11 p.m. For enjoying these wonderful discussions. And Dr. Ravishankar, any closing remarks from your side?
No, nothing. Already I told. Wonderful presentation, wonderful cases, very confident and clear presenters. And the experts were so, I mean, they're telling so many differential diagnoses and how to approach the case. It is really wonderful to listen to both the Nagbhushan sir and Kalapa sir. And we learned a lot. Frankly, we learned a lot. Thank you all. Thank you a lot.
Thank
sir.
you. Thank you all.
Thank you. Thank you, Pooja, for doing a wonderful job. And
thank you all. To all our viewers, thank you very much and look forward to meeting you again for the next edition of Case Samanvay. Thank you and good night.
Thank you.